Hannah said, so I've not taken any breaks. I've gone straight through. I've just sat my FRCS vascular. So I might have a few insights into kind of questions that might come up. Could everyone who's kind of a peri FRCS who wants to kind of participate kind of put their cameras on if they can? That would be nice. And we can start. I've designed this to be interactive. And what I've done is I've gone through so that there's no question bank for vascular FRCS, and so I kind of had to use a hodgepodge of the FRCS general surgery question banks, and there are a lot of questions in vascular that seem to come up routinely. So what I've done is I've covered the topics from those that seem to come up routinely, and I've kind of had a chat with some people that have just sat their general FRCS, and it seems that they seem to be along the kind of similar lines. So I hope this is helpful. So first question, topic is emergency aneurysmal disease. I can read them out, or do people want to just read them and shout out the answer? I'll read it out. So 59-year-old man undergoes CT colonography for change in bowel habit, identifies a 4.6 centimeter infrarenal AAA. His CTC was otherwise normal. With regards to his vascular follow-up, what surveillance schedule should he have for his abdominal aortic aneurysm? Someone shout out the answer. Otherwise, I can see Matt. So Matt, what's the answer? I'll give it a go.
Hi, George. Good to see you again. I don't know. Is it 12 months?
So, any advances on 12 months? So, the answer is a 3-monthly ultrasound of his aorta. And this is a question that seemed to come up loads, both on the On Examination website and on the EFRCS and Ed Smythe's website. So this is something that's quite high reward, easy to learn. It's probably going to be a question that comes up. So the AAA screening program was extrapolated from Gloucester, but all men over the age of 65 on their 65th birthday, they're invited for a one-off screening ultrasound of their abdominal aorta. If their aorta is less than 3 centimeters, 30 millimeters, then they're discharged and they have no further follow-up. If their aorta is 3 to 4.4 centimeters, they have a 12-monthly ultrasound, so an annual ultrasound. And if their aorta measures 4.5 centimeters to 5.4 centimeters, then they have a 3-monthly ultrasound. At 5.5 centimeters, they're referred to a vascular surgeon from the screening program. It's quite interesting that the screening program is completely separate to vascular surgery. There's a screening program director that is a vascular surgeon in the local unit, but until the patient is referred at 5.5 centimeters, they're not technically owned by any surgeon, as it were. But the evidence for this, again, some quite high yield points, is the multi-center aneurysm screening study, which published its 12-year results a couple of years ago. And all the surveillance intervals from this, so the 3 to 4.4, 4.5 to 5.4, is from the multi-center aneurysm screening study. In this study, patients are randomized to a one-off invitation to screening or not invited to screening. What it shows was it significantly reduced the aneurysm-related mortality. And at the latest follow-up, there was a reduction in all-cause mortality. So when the AAA screening program was started, it was started on the basis that it reduced aneurysm-related mortality, not all-cause mortality. Not sure it would have got funded, to be honest, if that was put forward now. But nowadays, the most recent follow-up, it's shown that it does reduce all-cause mortality, and that's probably because these patients are being seen and then their risk factors are being modified once they have a diagnosis of aneurysm. The second high-yield bit of information you need to know is what is the evidence that we don't operate until they're 5.5 centimeters. And that evidence comes from quite an old paper now, which is by Janet Powell and the group out of Imperial, and it's called the UK Small Aneurysm Study. And this is where patients were randomized to either early intervention or surveillance for patients who had an abdominal aortic aneurysm of less than 5.5 centimeters. I think it was over 4. And it showed that there was no survival benefit for those patients that had their intervention early. There's a lot of controversy or a lot of discussion now as to whether or not this paper is still relevant, given improvements in techniques. But at the moment, that's where that 5.5 comes from. So the UK Small Aneurysm Study. Okay, next question on the same topic. So you see a 72-year-old man in the emergency department who presents with collapse, abdominal pain and back pain. You clinically suspect ruptured abdominal aortic aneurysm. His systolic blood pressure is 90. His heart rate is 100. The patient's able to chat to you but appears somewhat in pain. What should be your priority with regards to their initial management? Somebody else?
Hi, George, it's Rosie. Would it be take them straight to theatre? Would that be the priority here?
So I take your point. So the answer to this question would be CT angiogram. Okay. And we'll go through each of the points as to why. Often you get these questions where what I was trying to do is write a question where the answer could be any of them. And part of the exam technique is trying to really tease out which ones are right. So crystalloid resuscitation, we know that's wrong. Okay, everybody knows that's wrong in a bleeding patient. Cross-match blood is definitely something you would do, but it's not really the priority. Then you get into the take them straight to theatre. So whenever you're thinking about a question in an exam and the answer is take straight to theatre, what you've got to think is, has this question told me that this patient is so unstable that the answer is going to be straight to theatre? And the salient points I've put in this question is, you know, the patient's able to chat to you, so they've got systolic blood pressure of 90, but they're still perfusing their brain. So the answer is not going to be take straight to theatre. There's another layer to this in aneurysm, in the management of aneurysms, which is that we need to confirm the diagnosis and plan an intervention. And we can't really do that without a CT angiogram. And that's why the answer is C in that case. So the key in emergency aneurysm disease is to manage the resuscitation. So that's permissive hypotension. We don't give TXA. We resuscitate like for like, and we get a CT angiogram so we can plan our intervention. So manage resuscitation, confirm the diagnosis, and plan your intervention. The CT angiogram is vital in planning the operative intervention, both endovascular. So we need the scan all the way up here if we're going to do an EVAR, because that's where our wires sit. Especially, it's really embarrassing if you fix an aneurysm down here and then they rupture from a massive thoracic aneurysm as well. So we always scan from the arch to the greater trochanters. But even when you're doing an open repair, we're seeing a lot less ruptures, firstly because of the decline in smoking, but also because of the screening program. So that means that those that are coming through are often missed by the screening program, and they're often more complex aneurysms. So we'll often find that in that rupture scenario, they may have a retro-aortic renal vein, it's a juxtarenal aneurysm, and going into those things blind are really not good for the patient or the surgeon. The second thing is that endovascular strategy for ruptured aneurysms has been associated with some improved outcomes. So we are leaning towards doing an EVAR if we can. Rupture mortality, 80% overall. And if they survived hospital, the mortality is about 40% for all comers. So what people are talking about now is the IMPROVE trial, which has published its long-term results. First thing to say is that in the IMPROVE trial, they randomized patients with a clinical diagnosis of ruptured abdominal aortic aneurysm. So this is senior registrars and consultant A&E doctors randomized patients who they suspected had a rupture to either endovascular strategy or open surgical repair before they had a CT scan. the misdiagnosis rate, so those patients that then had either bowel obstruction or a UTI or some other cause for their hypotension and collapse, was about 10 to 15%. So actually, when they're seen by an A&E consultant, they're pretty good. 85% of the time, they're pretty good at making the diagnosis. But there is a significant misdiagnosis rate, so always do a CT. Of those, we have to be able to plan an EVAR, but only half were suitable for EVAR in those that presented. However, if they were suitable for EVAR, so now we're getting properly down the road of selection bias, etc. The mortality was roughly 20%. So you do, if they can have an EVAR, if they're barn door suitable, they do appear to do better, and women did better with EVAR. Here are your risk factors for aneurysmal disease. I won't go into that too much. The question they love to ask is what factor is protective from aneurysmal disease, and it appears from the observational data that patients who have diabetes are protected from developing aneurysms. Whether or not that's because of metformin, we don't know, and there's a few British Heart Foundation trials that tried to go through that haven't yet been funded, looking at whether metformin reduces aneurysm growth, but we're not sure. And then favourites with regards to vascular are here. So FBN1 is Marfan's, COL3A1 is vascular EDS type 4. So weirdly, it's type 4 ethylestanolos, but it's type 3 collagen. Don't know why they did that, but that's how you remember it. COL3A1 and Loeys-Dietz, they're the three genetic vasculopathies you need to know. And then aneurysms elsewhere. So if you have a popliteal aneurysm, you have a 50% chance of having an aortic aneurysm. If you have an aortic aneurysm, you have a 10 to 15% chance of having a popliteal aneurysm. Those are the kind of easy questions they love. Right, change topic. So you see a lady in her 80s who presents with a white right painful leg. She's found to be an atrial fibrillation. When you examine the patient, you find she has no palpable pulses on the ipsilateral side, but has a full complement of lower limb pulses on the contralateral side. You are unable to isonate Doppler signals. She is unable to dorsal or plantar flex her foot, and sensation is absent to the knee. When you press the skin at the ankle, there is no capillary refill, and the leg appears mottled. Her calf is tense and tender on squeeze. Her initial blood test reveals CK of 8,000 and a creatinine of 300. Who wants to go next? What is the answer? Can you see the options there? Sorry, yeah. Somebody shout out. What is the definitive management of this patient? So option A, right popliteal embolectomy. Option B, right femoral embolectomy, 4-compartment fasciotomies. Option C, right fempop bypass. Option D, above knee amputation.
Is it D?
Oh, you need an amputation.
Yeah.
Yeah, so that's right. So D, amputation. So I put a number of things into this question, but I felt like I chopped off a lot of legs in my exam, and I think that in the practice questions on the FRCS and things, it seems to be similar. But what they'll often try and do is give you a few things that might tip you into trying to salvage a limb, but actually you really should be chopping it off. So you may have seen this situation clinically day to day, and we might try and revascularize a leg like this. And you may have seen consultants revascularize a leg like this, but really revascularizing this patient would be dangerous and potentially lead to their mortality. So the real important thing from this question, it's about severity of ischemia. So I know that you all know the 6 Ps of acute limb ischemia. We're kind of going way beyond that. They want you to identify how severe the ischemia is in the limb to decide whether or not the limb is salvageable. And the way you do that is with the Rutherford. So there are 2 Rutherfords to say. So there's a Rutherford for chronic limb ischemia, and there's a Rutherford for acute limb ischemia. So use the Rutherford for acute limb ischemia, okay? And that's split into 1, 2A, 2B, and 3, okay? So with this lady, key findings for her is it's all about the clinical assessment. So you can't isonate Doppler signals. She can't move her foot at all, so it's completely paralyzed, and she's got absent sensation to the knee. So they may only give you those factors in the exam question, but even with those factors, it makes you a Rutherford 3. So you have a profound aesthetic sensory loss, completely paralyzed foot with inaudible Doppler signals. And the kind of classic teaching is that you should only salvage 2A and 2B. Stage 1, these are the patients you can put on heparin, try and get them to walk, and they might be all right. They don't need an operation. They may not need an operation at all. They could have a delayed angioplasty, let's say. 2A and 2B, they need an operation. 2A needs an operation in the morning when you get in nice and fresh. 2B needs an operation immediately. And a 3 essentially needs an amputation or a palliation. That's the way to think about it for the exam. It may not be what you do in clinical practice. You may try and revascularize a few of these 3s. But for the exam, if they're a 3, so if they've got, abnormal movement sensation and a paralyzed foot, then they really should be having palliation or amputation with regards to the question. I put a few more things in here just to make it really clear. So if you see fixed mottling, so when you press the skin, no capillary refill, if it's fixed mottling, then the patient needs an amputation or palliation. And then to add a few things on here, this patient's clearly unwell with a high CK and renal failure. And so revascularizing them would probably lead to their demise. Any questions on the Rutherford acute limb? No. Let's carry on. I'll try and stick to time. Kind of did five minutes on each question. So which of these options would suggest acute on chronic limb ischemia? So a full complement of contralateral pulses, normal movement sensation or Rutherford 1, a recent MI or penetrating trauma.
Recent MI?
Nikki said recent MI, did you? So
It's Lydia here.
Oh, Lydia.
Because I thought maybe that implies that they've got other ischemic disease elsewhere in their body.
Not quite. Any advance on recent MI?
Normal movement and sensation.
Yeah, that's right. So the key thing here is we're talking about the difference between embolus and thrombosis. Okay. A full complement of contralateral pulses would suggest that the patient's had an acute event in the ipsilateral leg, which means the ischemia is likely to be profound. That's the same thing with penetrating trauma. They're likely to have normal blood supply, and therefore the ischemia induced is most likely to be profound. MI in the context of limb ischemia, normally the questions are all about embolus of mural thrombosis, if you see that, rather than perfusion, Lydia, but I get what you were thinking. But normally if you see recent MI there in the context of an exam question, they're talking about embolic event. So here it would be normal movement and sensation, or if we're going back to here, Rutherford 1. So the limb is viable, it's white and a bit cold, but they've got normal movement and sensation. So we go on to the etiology of limb ischemia. So you've got embolization, and classically the ones they love to talk about are AF, mural thrombus, aneurysm, and prosthetic heart valves. And then in situ thrombosis, which is your plaque rupture, dissection, and trauma. The ability to kind of distinguish between embolus and thrombosis is useful. So emboli tend to lodge at bifurcations, and that's why the severity of the ischemia is worse. So if you imagine you throw off a clot from your heart and it lodges in your common femoral, you occlude both the SFA and the profunda, and therefore the ischemia is much more profound. if you just have an SFA stenosis or SFA atheroma that then thromboses, what will happen is it will thrombose all the way up to the branch point. That's why you get a full-length SFA occlusion, but the profunda will still be running. So the patient will present with an ischemic leg, but it won't be quite as profound because the profunda is still going. And these are the patients you might be able to get away with managing with anticoagulation. But on both sides here, you can see the difference between thrombosis and embolus. Often with thrombosis, they have a preceding history of claudication and risk factors for peripheral artery disease. And as I said, it's less severe. Anything I didn't say here? No. So the key thing with embolus is the classic thing in your exam question will be that they have pulses that are present on the other side. Okay. Any questions on that before we move on? Okay, 20 minutes. Okay. So next scenario, so critical limb ischemia / chronic limb threatening ischemia. So 74-year-old gentleman presents with gangrene of the left hallux. He has rest pain and is not sleeping and is therefore admitted to hospital. He undergoes CT angiogram, which demonstrates he has no significant aortoiliac disease. He has a 75% common femoral stenosis with a preserved profunda femoris, a full-length SFA occlusion with reconstitution of the Bloney popliteal. The PT is the best vessel to the foot and crosses the ankle. The AT occludes mid-calf and the perineal is thready. He has a vein map that shows a 2 mm GSV in the ipsilateral leg with evidence of previous DVT in the DVT, and the GSV in the contralateral leg has been taken for previous CAVG. What is the optimum surgical management for this patient? So A, common femoral endarterectomy, B, common femoral endarterectomy and fempop bypass with ipsilateral vein, C, femoral endarterectomy angioplasty of the SFA. Sorry, I said femoral artery angioplasty and SFA angioplasty. Common femoral endarterectomy, fem-PT bypass with PTFE, or common femoral endarterectomy and fem-pop bypass with PTFE.
A.
Who's gone for A? Sorry.
Me.
Nick, you went for A. Matt, you went for A.
Just seems the others are pretty aggressive, and you could improve the inflow, and with a preserved their profunda, then that might be adequate to give them contralateral flow down to the rest of the leg.
That's exactly what I wanted you to say, but the answer is D. So you're completely right. So there are there's quite a lot to discuss in this scenario, but go with Nikki's point first, which is you can just do a common femoral endarterectomy and improve the inflow. So in the context of gangrene, there's first thing to say is it's normally multi-level disease. So they'll either have aortoiliac disease, of which the common femoral is normally included, or they'll have multi-level, so above knee and below knee disease. Okay. In this patient, they have 2 levels of disease that we should really treat for their gangrene. So they have the common femoral and the SFA. And so I completely agree. In a patient where you're just trying to tip them out of rest pain, so they've got a sunset foot, they don't have gangrene, they've got a lot of pain, maybe they're a bit high risk for a bypass, then I completely agree. Doing a common femoral endarterectomy alone would be enough. In the context of gangrene, that wouldn't be the right answer or not enough in terms of a purely exam setting. You're right that maybe the patient just needs a quick operation under local, and clinically in our practice we might give them a common femoral, but we're being pernickety about, these are the type of questions you get where all the answers could be right, but in terms of the questions only one is. So in this question there are a few factors. So first thing is multi-level disease, gangrene, you need to revascularize with inline flow. That's the key buzzword that they use. So in order to get inline flow here, we're going to have to do some kind of bypass. For exam questions, the vein really should be 3 mm in size in order to be a suitable conduit for bypass, although you may have seen people just get the vein out, blow it up and see how it goes. But for this question in an exam, I would put FemPop bypass with PTFE. I put FemPT bypass in here just to throw you off, because the way in which the question is written, it says the PT is the best vessel to the foot, but the below knee popliteal is reconstituted. So there is inline flow from the popliteal all the way down to the PT. And there's no option for contralateral leg vein because it's been taken for previous bypass. And the final thing to say is he has a relative contraindication to taking the vein out of the ipsilateral leg, and that would be that he's got evidence of previous DVT. So if you take out the superficial venous system, his leg may just completely swell when you revascularize it, and that would be a nightmare, and his gangrene would break down. So that's why it's E. So new definitions. I don't know if these will make it into the general surgery FRCS. So I've put them both in here. The simplest thing to learn would be critical limb ischemia. So rest pain, tissue loss, and an ABPI of less than 0.5. That's easy. CLTI is it's been developed to encompass the broad range of lower limb ulceration that we see. And now we're seeing a lot of patients who have mixed disease, who have, even traumatic ulcers that aren't healing because they have a bit of underlying PAD, and they're not your true PAD, critical limb ischemia patients. However, the bulk of our workload is CLTI, which is why the terminology has changed. But the definition of CLTI is here, if it does come up. The reason why this has changed is so the global vascular guidelines were released in 2019 from the ESVS and the Society of Vascular Surgery. Ideally, we should be revascularizing patients within 5 days as an inpatient and within 14 days as an outpatient. The goal, as I said, is to restore inline flow. And key thing on this question is gangrene rarely occurs with a single level of disease. Normally, there are multiple levels of disease. Conduit for bypass, vein is best, 3 mm in diameter for exam questions, and ideally the deep venous system is patent. And the evidence for that is a Cochrane review by Chris Twine and Graham Ambler. That's easily Googleable on the internet. So next question. So a 74-year-old lady, presents with right leg rest pain. She's Berger's positive and is having to hang her leg out of bed at night. You cannot feel a femoral pulse, and therefore you've arranged a CT angiogram. This demonstrates a common iliac stenosis of 2 centimeters in length. What is the most appropriate intervention? A, aortofemoral bypass, B, iliac artery angioplasty, C, iliac artery stent, or D, fem-fem crossover. Any takers?
I would say C, maybe. I think
B or D?
Sorry,
say again.
C, a stent. I wonder if 2 centimeters is potentially too long for an angioplasty, and A and D in a 74-year-old at this stage maybe seem a bit much. Good.
So I like your thinking, close, but the answer's angioplasty. Okay. So this question I thought was really harsh to be in. So it's in this type of question is in all 3 revision modules that were out there. So on examination, the FRCS, and Ed Smiley's one, which I thought was really mean because the evidence around all of this is terrible. So there is no right or wrong answer, and the jury is still out. There's very limited evidence to guide practice in this area. Firstly, with regards to which lesions you should stent primarily, which lesions should have angioplasty primarily. In general, this is basically what I learned for the FRCS vascular, but this is what I would learn for the FRCS general surgery, just for simple things. So in short stenotic occlusions, where the lesion is less than 3 centimeters, I did primary balloon angioplasty. Long stenotic lesions, so over 3 centimeters, probably consider a stent, but the jury is still out. Short occlusive lesions, it's probably a primary stent. Again, the jury's still out. And long occlusive lesions, I do a bypass of primary stent. Probably long occlusive lesions, bypass, short angioplasty, and in the middle it's going to be more difficult to work out, because I mean, you know, in the when you're doing it in Viva, you have to just justify your answer. In the MCQ, it can be a bit more difficult. And where this all comes from, the 3 centimeter thing in the general surgery FRCS is from the task classification, so the Transatlantic Society of something. But essentially, task A and B are treated with endovascular means traditionally, and task C and D are treated with open surgical means. That's the traditional way of looking at it. So A and B, so short, less than 3 centimeters, or short occlusions, then you should treat them with endovascular means. C and D, which is complex occlusion, so D is really easy because they have an aorta bifem, and C, these are the ones that we're now treating with hybrid means. So often when they're having a common femoral endarterectomy, for example, this one here, and then an iliac angioplasty. But traditionally, A and B, endo, C and D, surgery. And I think that will probably be the right answers in the exam. So moving on to PAD, you see a 62-year-old gentleman with claudication that's starting to interfere with his life as he cannot walk to the shop without stopping. He's claudicating at 200 yards, type 2 diabetic, had a TIA 7 years ago and smokes 5 cigarettes a day. He has a duplex scan which reveals a 75% stenosis of the mid-SFA, and his ABPI is 0.6. What's the most appropriate initial management of this patient? Any takers? Start picking some names.
Is it medical therapy because it's initial management?
Yeah, that's a good shout. Specifically to this question, though. Okay, so the answer here would be supervised exercise therapy. I don't want to run over, so supervised exercise therapy. So you're right that you must instigate the right medical management, but we're dealing down with the nitty-gritty in this case. So nice guidance for PAD would be clopidogrel and atorvastatin, and you see it all the time in these MCQ type questions. Is they'll put something that's kind of right, but it's not the correct guidance. So here, aspirin and simvastatin would not be the correct answer, because current nice guidance is clopidogrel and atorvastatin. SFA angioplasty and stent could be considered, but only in patients when they failed initial conservative management, and a bypass is pretty full on for claudication. So in terms of nice guidance on claudication, again, it's something that comes up really commonly. Clopidogrel and atorvastatin is best medical therapy, and that's really prescribed to reduce major cardiovascular events in patients with claudication. So I think at 5 years, a quarter of patients will have had some kind of major cardiovascular event. So most of them die from heart attacks and strokes. Supervised exercise therapy has been consistently shown to be as good as primary endovascular intervention. Endovascular intervention is quicker, so often it has better quality of life scores when compared with supervised exercise therapy, and there are 3 big trials in this area. But there are also some big retrospective studies that suggest that early endo intervention is associated with earlier limb loss. And supervised exercise therapy is, of course, more cost effective than endovascular intervention, and therefore that's why it's recommended by NICE. On top of that, don't forget smoking cessation therapy. This is lifted straight from NICE guidance on claudication, so when to intervene. The classic question in the FRCS is usually about patients with aortoiliac disease and when to offer them an aorta bifem. So ideally, they would have supervised exercise therapy first, and if they failed that, then you move on to angioplasty. And if angioplasty is not appropriate or not suitable, for example, in aortoiliac disease, then you would consider bypass surgery. Okay. How are we doing for time? Got 10 minutes. So carotid disease, which of these is caused by symptomatic carotid stenosis? Ataxia, drop attacks, central retinal artery occlusion, or ipsilateral hemiplegia? Pick another person. Hannah, seeing as you spoke earlier, what's the answer? Oopsie. Oh, I've given it away. Whoops, sorry. Did everyone see that?
Central retinal artery occlusion, George.
Yeah, great. So yeah, I think I got this wrong when I was practicing, and I clicked ipsilateral hemiplegia. You just got to be really careful with the wording and your exam technique. So don't forget that a carotid stenosis will cause contralateral hemiplegia. It's a really, really easy thing to just slip up and get wrong, and that's 1 mark in your exam. So it would cause an ipsilateral central retinal artery occlusion. These are the stroke syndromes that you can see here. The thing with carotid disease is that they talk about the circle of Willis being a circle. It's not really a circle. It's 2 halves which are connected by the posterior communicating that's absolutely tiny, and no embolus ever goes down in terms of carotid disease. So therefore we're only really interested in anterior circulation strokes. So if the patient has, these ones down here that are posterior circulation strokes, then we're not really interested in that. So anterior cerebral, middle cerebral, and the ventricular striate. So everything forward of here. So 54-year-old patient presents to stroke physicians with a right upper limb TIA, high blood pressure, and no other significant risk factors. 20-hour outtake that's normal. So which of the following duplex ultrasound findings would be an indication for carotid endarterectomy for this patient? Shout it out, someone.
Is it C?
It is C, yeah. So C is the answer. So ICA stenosis. So originally this was measured using angiography, and the 2 big trials in this are the North American carotid surgery trial, NASET, and the European carotid surgery trial, ECST. And the narrowings are initially based on angiography. When you do your angiography, you get a picture like this. And NASET, which is the American one, uses the distal ICA here as the denominator. And therefore the stenoses are slightly different. You can see here that a NASET 50% is an ECST 75%. There was a big reanalysis of all the carotid data by a chap called Peter Rothwell, and it was all reanalyzed using NASET. So essentially, no one uses ECST anymore. So you shouldn't be given an ECST value in your FRCS general surgery question. For the purposes of that, I would learn this. So based on NASET, less than 50%, no indication for surgery. 50 to 69, surgery indicated. 70 to 90, surgery indicated. Greater than 90, surgery indicated. If you have an occluded ICA, then there's no indication for surgery. Normally, we confirm this with 2 modes of imaging. And if you see something called trickle flow or string sign, there's no indication for surgery. Okay. Any questions on carotid before we move on? Got a few minutes left. So 45-year-old lady with type 1 diabetes who stepped on a nail. Her foot is red hot and swollen. You can feel crepitus just above the ankle. CRP of 450, white cell count 14, DKA on presentation, creatinine 250 and CK of 5,000. Foot x-ray is shown. What's the definitive treatment option? Anyone?
I missed the options, George, and I can't see them anymore. Sorry.
Sorry, yeah. I was looking for names to pick.
Baloney amputation, because she's got neck fash.
Yeah, that's certainly an option.
I'd say A because she's very unwell and it would be a quicker operation.
Yeah, so this question does come up quite a lot. I think the difference between A and B, Nikki, is that A and C is that C requires you close the flap, and that's the difference in it. So when I was doing these practice questions, yes, the patient needs their foot off. You both know that, but the guillotine amputation essentially allows you to take off the bit. We've gone to just above the ankle, take off the bit that's got the neck fascia in it, and send them to ITU and then bring them back, because if it just keeps going, you may just need to do an above knee amputation. If you do a below knee, you're going to have to close the flap, and you're not really sure about the viability of the tissues. So the kind of what all the practice questions have suggested is that guillotine would be the right answer in this scenario. If you see the words, so as I said, I felt like I cut off a lot of legs in FRCS, but if you see the words crepitus, gas, or fixed mottling, the answer is cut off the leg or palliate. And they'll often try and throw something in there that will make you not want to do it, like the patient's really young or something like that. Or, you'll read it and go, really, are we going to cut their leg off? But if you see these words in that question, it's normally cut the leg off. They love this question about the types of necrotizing fasciitis. Type 1 is the perineal neck fash that we see in general surgery. Type 2 is the plastics neck fash, or the really fast BT hemolytic strep A. And then type 3 is the one we see in diabetes with Clostridia gas gangrene. So this is another favourite. So 32-year-old man presents to your clinic with gangrene of all the digits on his right foot. He's a heavy smoker, terrible rest pain, and is therefore admitted to the vascular ward and arterial duplex performed. This shows excellent inflow to the level of the knee, and all 3 tibia vessels are occluded. The patient goes on to have a diagnostic angiography via the right groin. What is this most likely to show? Anyone? Go for it. Shout it out. Give it a guess. We're all friends here.
Is it occluded tibial vessels with corkscrew collaterals, because this is Berger's disease?
Exactly. So the answer here is Berger's disease. The clue in the question is young man. Okay, so young man who smokes. You've got to think Berger's disease. So a young patient with gangrene, you're either in the upper limb or the lower limb. Your mind should immediately go to Berger's disease. They'll often give you, there are a few kind of classic phrases and corkscrew collaterals. If you hear corkscrew collaterals, you think Berger's disease immediately. String of beads appearance is associated with fibromuscular dysplasia, and normally you see that appearance in the renal arteries in a patient with resistive hypertension, normally a young female patient. So they absolutely love this question. It comes up all the time. So thromboangiitis obliterans, small and medium-sized blood vessels. It's a vasculitis caused by smoking. The key thing here is there's preserved internal elastic lamina. That's the key buzzword. If you didn't have preserved internal elastic lamina, does anyone know what that would suggest? So that would make it more likely to be giant cell arteritis. What you've got to remember is there are some other vasculitis, including Takayasu's, which affects, and mid-aortic syndrome, and they're pan-vascular disease, so they affect all 3 layers of the aortic wall. And giant cell arteritis and Takayasu's are histologically indistinguishable, but you distinguish them based on their clinical syndromes. So everybody knows the clinical syndrome of giant cell arteritis with your headache, etc. Takayasu's is usually young women, and they present with coarctation type syndrome because they have a narrowing of the aorta. Keep going quickly, sorry. So quick one here. So called to see an 18-year-old female stabbed in the thigh. Which of these is considered to be a soft sign of vascular injury? A hematoma, palpable thrill, absent pulses, ischemic limb, or active pulsatile hemorrhage? Someone go for it.
Hematoma?
Yeah, exactly. Hematoma is the answer. So again, another question that they absolutely love is the difference between hard and soft signs of vascular injury. So hard signs are here, so expanding hematoma, absent pulses, blah, blah, blah. Soft signs, so hematoma, the history of excessive bleeding, any adjacent nerve injury. So, you know, if you have an ulnar nerve palsy, you're likely to have injured your ulnar artery, and unexplained hypertension being soft. The old blunt trauma unstable patient scenario, they will tell you if they're unstable in the question, and if they are unstable, the answer is theatre in these MCQs. If they are stable, then do a scan. Seems to be that whenever I've gone, oh well, they could have aortic transection, it doesn't really pan out. So if they're unstable, they go to theatre. Quick, I think last two. So 74-year-old female referred to your clinic consideration and diagnosis of chronic mesenteric ischemia. Which of these options is not considered a classical feature of chronic mesenteric ischemia? Oh, sorry, I've done it again. Yeah.
C.
Correct. So the answer is C. And the reason is that chronic mesenteric ischemia is diagnosed with exclusion. In these questions, they're always going to give you that triad of weight loss, food fear, and postprandial abdominal pain, and that's considered to be the classic clinical diagnosis. Single vessel occlusions rarely cause chronic mesenteric ischemia, and that's because of the collaterals from your SMA and your celiac via the inferior pancreatic duodenal. So in order to have significant mesenteric ischemia, normally they need to have two vessels occluded, so maybe celiac and IMA or SMA and celiac. In terms of when you're thinking about intervention, so short proximal stenoses of the SMA, you could consider endovascular intervention. Longer occlusions or aortic disease or the need to revascularize more than one territory, so celiac and SMA, an open solution is normally the one you'd go for. Last one, I think. So you take a patient to theatre for acute mesenteric ischemia. The patient is in new atrial fibrillation. At laparotomy, you notice a small bowel is dusky and the terminal ileum is clearly necrotic. The duodenum and the transverse colon appear to be spared. Where is the SMA embolus likely to have lodged? A, the origin of the SMA. B, distal to the first branch of the SMA. C, in the proximal ileocolic artery. And D, in the jejunal branches. Someone go for it.
Just distal to the first branch?
Yes, exactly. So this is again another classic question, and the thing they love to describe here is that you get sparing of the transverse mesocolon and the duodenum, because in an embolus it's more likely to occlude just distal to that first branch where it's just here. So the middle colon comes off and it lodges about here. So then you get sparing of the duodenum, the transverse colon, and that's the classic pattern that you'll see. So in the same patient, what would be your optimum strategy for approaching the SMA? A left medial visceral rotation, transverse incision at the root of the mesentery, a right medial visceral rotation, or through the lesser sac?
Is it the right medial visceral rotation?
So not in this context. So here we'd go for a classically. So they love this question as well. So approaching the SMA. So you lift the colon cephalic and you bring all the small bowel towards you, so you've got it in your hand, and you feel the root of the mesentery. And generally, we then make a transverse incision where essentially where the middle colic comes off, because it allows you to then perform bypass and embolectomy. If you did a right medial visceral, so you can reach the root of the SMA this way, you leave the kidney down, take the right colon all the way up, take the duodenum up, you go above the renal vein, and then you only have like that much of the SMA, and that's what you do in transplant surgery when you're doing your medial visceral rotation, but you wouldn't be able to perform embolectomy through that incision. Via a left medial visceral rotation, you can get like that much of the origin of the SMA, but again, it's quite difficult to perform bypass in that position. You can do endarterectomy in that position, but doing bypass, it's more difficult. So the classic answer here would be B. This question does come up a lot, as I said. And then finally, a tip for when you get asked in your viva, endovascular strategy for acute mesenteric reconstruction. So I just learned this and I stuck to my guns. So does the patient have peritonitis? Yes or no? So clinically, does the patient have peritonitis? Yes, they need laparotomy, a bowel resection initially, and then either an open or hybrid revascularization. Does the patient have peritonitis? No. So you may just pick up that they're a bit distended, they're not that tender, their bloods aren't that bad, and they're not septic. Then at that point, you could consider endovascular revascularization. However, you then get into when do I look at the bowel? Do I put a laparoscope in? So in terms of exam answers, just say, does the patient have peritonitis? Yes or no? Yes, they get a laparotomy. No, then you may think about revascularization endovascularly. But even if they don't, you're not going to be wrong to say you do a laparotomy. I hope I've just run over a little bit, but I hope that was useful and gave some context in terms of the type of questions and the way they may ask them, and I hope those that'll help.
George, there was just one question from Manic, and it was going back to the neck fash patient who is going to have an amputation, and the question is, why do you have to close the flap for BKA?
You don't, but we're getting into the nitty gritty of questions here, and that's kind of what you're going to read a lot of these questions when you do your exams, and yeah, you're going to get a lot of these questions where you go, that's right, and you've got to make a decision. You've got less than a minute per question in your MCQ, and I guess you're right. You can do a below-knee amputation and leave the flap open, and if that's what it said in the MCQ, then yeah, I would probably pick that answer. But by the nature of the guillotine amputation, it's always left open. So in that question, where the option is BKA or guillotine, the answer is guillotine. So I'm not disputing that you're right. You can do a below knee and leave the flap open. That's fine. What we're talking about is preparing you for the FRCS questions and thinking about it in a question format. I hope that answers your question, Manic. I hope that's okay. Sorry if you lost signal. I'm in Scotland in a lodge somewhere. Thank
you, George.
Great.
No worries.
George.
Have a good day, guys.
Thanks
See you
for
later.
that. Everyone really appreciates it.
Bye, guys.